At ESMO, we also had the long-awaited data from the ETOP STIMULI trial presented by Professor Peters. This is a really highly anticipated trial where patients with limited stage small cell lung cancer who were enrolled into the trial, recruited, and underwent protocol-mandated chemo-radiotherapy concurrently with PCI were then randomized to receive either follow-up alone, according to the protocol, or intervention with Nivolumab and Ipilimumab. Nivolumab was given at 1 mg per kg, and Ipilimumab was given at 3 mg per kg for a total of 4 cycles, and thereafter there was Nivolumab maintenance for 1 year. This was a difficult trial to recruit to because, limited stage small cell lung cancer is not as common a disease as it used to be many years ago, and patients had to go through the protocol mandated chemoradiotherapy with PCI to be able then to be randomized. So of course there will be attrition of cases throughout that standard of care treatment. Ultimately around 70 patients in each arm were randomized, and the primary endpoint was overall survival and progression-free survival as a co-primary endpoint, but that was subsequently modified due to low recruitment to progression-free survival. Unfortunately, there was no progression-free survival advantage seen for the immunotherapy, and also no overall survival benefit seen, but perhaps a signal that there may have been some benefit in the twice-daily radiotherapy group. Of course, one of the reasons why this might have been an issue was the high rates of discontinuation seen with immunotherapy. The commonest cause of discontinuation of the trial in the non-immunotherapy group was disease progression, as you'd expect, but around half of the patients discontinued due to immunotherapy toxicity. And we saw really quite a high rate of grade 3 plus immune-related adverse events in the immunotherapy arm, given the higher than usual dose of Ipilimumab used in the trial compared to now. But you've got to remember that the trial was designed many years ago when 3 mg per kg of Ipilimumab was thought to be very reasonable dosing for small cell lung cancer at the time. So overall, checkpoint inhibitor consolidation has no PFS or OS advantage. The tolerance was not good, and that probably accounts for the lack of efficacy that we're seeing due to a lack of exposure. We do know that there is a strong benefit from PD-L1 inhibitors, both durvalumab and atezolizumab, for metastatic patients from the Caspian and IMpower 133 trial, and there are several trials ongoing with PD-1 and PD-L1 inhibitors in the limited stage lung cancer setting, and I think these are really of great importance, and we're all very much looking forward to these data sets. So for me, it's still a very open question as to whether we should be using checkpoint inhibitors in limited stage small cell lung cancer, and I for one am very much looking forward to the single agent immunotherapy data which is forthcoming.